Hey guys, welcome back to my channel, The ENT Resident. Today I'll be discussing about the different osteotomies that is done in rhinoplasty. And this is a very commonly asked your theory question in your university exams, and it's quite important to understand this also because this is a very integral part in the procedure of rhinoplasty. We'll talk about what is osteotomy, why are we doing the osteotomy, what are the different types of osteotomies that are there. We'll discuss the approaches to these osteotomy and the steps of it. And lastly, we'll end with the complications of osteotomies. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, what is osteotomy? Osteotomy is actually the controlled surgical fracture or cutting of the nasal bones to reposition them. So we know that our external nose has three parts. It has the bony vault, then it has the upper cartilaginous vault, and then it has the lower cartilaginous vault. To know more about the surgical anatomy of nose in relation to rhinoplasty, I have put out a separate video on this. You can check it out to understand it more. So coming to the bony vault, one of the bones on the bony vault is the nasal bone. So osteotomy is how we are introducing a controlled fracture in the nasal bone so that we can actually reposition them. And the word osteotomy literally means bone cutting. Now, what is the reason? What is the purpose of doing osteotomies in rhinoplasty? We have multiple purposes here. So, if you remember the steps of rhinoplasty, after we have removed the hump, after removal of the hump, the next thing what happens is because you have removed the hump, now there is an open roof deformity left behind. So, if this was the nose, let me draw a side view. This was the nose, this was the hump. After you have removed this whole hump, what remains behind over here is a gap. The nasal bones are left kind of as two separate edges. The reason why we are doing osteotomy is to close this gap. This gap is known as an open roof deformity. So one of the prime purposes of osteotomy is to close this open roof deformity. Second is the next step after hump removal is narrowing of the nose. So if the nose is quite wide, we are going to be narrowing it. So osteotomy is a way that will help us in narrowing the wide bony vault. Next, if there is a deviated bony pyramid, osteotomies will also help you in straightening up the deviation of the bony pyramid. And lastly, if there is any kind of asymmetry of the nasal bones, that can also be corrected using osteotomies. So these are our purposes of doing osteotomies during rhinoplasty. Now let's try to understand what are the different types of osteotomies that we have. Now first I'll tell you the different types and a little bit about it, and next we'll go into the steps of each of these osteotomies. So first here we have three types of osteotomies. We have the lateral osteotomy, we have medial osteotomy, and we have transverse osteotomy. Starting with lateral osteotomy. What is this exactly? So in lateral osteotomy, as you can guess from the word itself, we are making a cut here along the side wall of the nose. If we look at this image over here, these are our two nasal bones. This is our side wall over here. So lateral osteotomy is a cut that is made along the side wall of the nasal bone, running from the level of the piriform aperture upwards. Now, the purpose of lateral osteotomy is here, what we are trying to do is we are trying to free the nasal bone. So, if you remember the anatomy over here, we'll remember that this is our nasal bone, right? Beside this, this is the frontal process of maxilla. Now, what we are trying to do here is we are trying to free the nasal bone in this region over here so that we can push it inwards to narrow the nasal vault, to narrow the bony nasal vault. So basically, a lateral osteotomy is a cut that we are making along the side wall of the nasal bone on the lateral aspect, and the purpose being we are trying to push the nasal bone inwards to narrow the bony nasal vault. Now, you have to remember that all types of lateral osteotomy will be narrowing the airway to some extent, as you can see, because we are narrowing the nasal bony vault. So that's a lateral osteotomy. Now, lateral osteotomy in itself are of different types. What are these different types that we have? So we have, first of all, it can either be conventional or it can be a curved type. Now, conventional type is the most classic, most basic technique that we usually use. Now, what happens here? Here we give a very straight cut. We give a very straight cut like you can see over here, and this straight cut is directed from the piriform aperture upwards to along the nasal bone. So this is a conventional cut. The curved type is when we are following the natural curve of the nasal bone. If you look over here, this looks more of a curve type. We'll be following the natural curve of the nasal bone rather than giving a straight incision. We'll be giving a curved incision over here. The importance of giving a curved osteotomy is that it will help you in preserving something which is known as the Webster's triangle. If you look at the image over here, this is our nasal bone over here. This is our piriform aperture. The Webster's triangle is this small bony triangle at the base over here. When we give a curved curved osteotomy, curved lateral osteotomy, it will preserve this triangle, which is very important for maintaining the alar support and preventing the collapse of the nostril. So that is the importance of having a curved osteotomy. And when you do a curved osteotomy, it often negates the use of a medial osteotomy. So that's our first two types. Next two types is based on the approach that you are taking for lateral osteotomy. So it can be internal or external lateral osteotomy. Internal meaning, as you can guess already, that we are introducing the osteotome through the nose, through the intranasal route. Whereas in this internal approach, we are not giving any external scars. So as a result of which, there will be less visible trauma and lesser degree of ecchymosis and edema occurring around the eyelids. So, but however, because we are going internally, the visualization is a little more difficult than the external approach. So, this internal approach may actually be a little bit less precise. Whereas the external approach is when we are performing this by giving multiple skin incisions. So we give tiny stab incisions on the skin surface using a 2 millimeter osteotome. And the advantage of the external lateral osteotomy is that it has greater precision, and however, this will also have a more chance of causing post-operative ecchymosis and edema around the eyelids. So this is about lateral osteotomy and the different types of lateral osteotomy. Next, we are going to be talking about what is medial osteotomy. Now, as you can guess from the word itself, if you look at the image over here, medial osteotomy is when we are giving a cut along the midline of the nasal bone. So this cuts over here that you're seeing along the midline of the nasal bone, which is very midline of the nasal dorsum. And the purpose of the medial osteotomy is that we are trying to separate the two nasal bones away from each other so that we can move them independently. Now, this medial osteotomy, it can be an oblique or a vertical cut. Medial osteotomy's purpose, I will talk about a little more later. It is only used in cases of significant deviation. So in lateral osteotomy, we were basically trying to move the nasal bone inwards. With medial osteotomy, we are trying to separate the two nasal bones out from each other so that they can be moved independently. And lastly, we have transverse osteotomy. As the name suggests, this portion over here is transverse osteotomy. As the name suggests, transverse osteotomy is basically a horizontal cut that we are making along across the top of the nasal bone. Now, the reason of a transverse osteotomy is that it is acting as your upper limit of the bone movement. So we will not go beyond this level. This will be our upper limit of bone movement while doing rhinoplasty. And this, when we give the transverse osteotomy, it completes the mobilization we need to move the nasal bones when we combine it along with both lateral as well as medial osteotomy. So here we have three osteotomies. Lateral osteotomy, which we have given along the side wall of the nasal bone. The purpose being we are trying to move the nasal bone inwards. Then we had the medial osteotomy, which we give along the midline of the nasal dorsum. Purpose being we are trying to separate the nasal bones from each other so that we can move them independently. And lastly, we have the transverse osteotomy, which is a horizontal cut, and this is acting as your upper limit of bony movement in the osteotomies and rhinoplasty. And if you look at this image over here also, this is what a lateral osteotomy cut will look like, and this is where the medial osteotomy cut is given. So that's about the different types of osteotomies. Next, let's talk about the different steps in each of these osteotomies, starting with lateral osteotomy. So in lateral osteotomy, first of all, let's know where are we giving the lateral osteotomy. So the position is usually marked along the nasofacial groove with help of gentian violet. Now gentian violet will particularly help in cases of beginners, and it will act as a guide for you to palpate the knob of the osteotome through the skin as you move the osteotome or chisel up as you perform the osteotomy. So gentian violet can act as a marker to guide you along the right path. So this is the position of lateral osteotomy. One more thing is, usually in the region of the root of the nose, we prefer to do a high osteotomy over a low osteotomy. And second, after lateral osteotomy, we are left with a space, right? The space that is left when we are shifting the lateral wall of the nose inwards. This space that is left behind, it actually over time gets obliterated by osteogenesis process. Next, let's talk about the different techniques. So we spoke about there is an internal approach and there's an external approach. First, let's talk about the internal approach, where we are doing the osteotomy from within the nasal cavity. So what are we going to do here? First of all, we will be injecting a little bit of local anesthetic along the nasofacial groove to supplement the anesthesia that you have already given. So here we are passing the needle through a point in the piriform crest, and we pass it upwards between the nasal skeleton and the skin, and we deposit a little bit of the anesthetic over here while we are withdrawing the needle. Next is our incision. If you look at the image over here, this is what our incision will look like. We'll make a stab incision about 0.5 centimeter in length with the help of a number 15 blade in the piriform crest region just in front of the attachment of the inferior turbinate. Once we have made this incision, we are going to incise through the soft tissue and the periosteum. And it is important to remember here, if you remember the rhinoplasty procedure, we had used an intercartilaginous incision in our closed rhinoplasty. We should never be joining both this piriform and the intercartilaginous incision because that will lead to post-operative scarring. So now we have made an incision and we have incised the soft tissue periosteum. Next, what we are going to do is we are going to elevate the periosteum. So if you look at this image over here, we have introduced our instrument over here, and we, at the help of this elevator, we are going to separate the periosteum alongside this frontal process of the maxilla, and we are going to try to create a tunnel. Once we have separated the periosteum and created the tunnel, we are going to elevate the periosteum, and this is done superficial to the medial canthus. It is done superficial to the medial canthus near the upper end, and the reason being we are trying to prevent injury to the medial canthal ligament or the lacrimal sac. Now that your subperiosteal tunnel has been created over here right up to the root of the nose. Now what we do is we are going to introduce, if we look at this image over here, we are going to introduce the Joseph's saw. Now, this saw is introduced very carefully along the frontal process of the maxilla, along the nasofacial groove. And the teeth of the saw, as you can see in this image, this should be facing against the bone for easy introduction so that you do not end up causing any kind of soft tissue injury. Next, we'll place the position of the saw such that it is at right angle to the surface of the bone. And since we are doing this in the internal approach and we are not able to see this, we will determine the position of the saw by palpating over the skin with the help of our left hand. And you have now positioned the saw properly. Then patient's head is turned to the side and immobilized by the help of your assistant. Next step would be the frontal process that you're seeing over here. This portion over here, the frontal process is sawed through its entire length in the nasofacial groove without cutting the mucosa. And the technique to remember here is that we should cut with the tip of the saw first and then gradually cut the bone from above downward. And you have to be very careful about applying very little pressure on the saw so that it does not get jammed between the bony grooves and the edges of this saw over here. So we are going to be very careful, and the movements of the saw has to be controlled, very well controlled and guided with the help of your left hand fingers. So we are using the saw to cut through the entire length. Now, alternatively, if we are not using the saw, we can use some other instruments as well, like the osteotome or chisel. So you can introduce the osteotome or chisel as well through the same stab incision that we made, the piriform edge incision. And use of osteotome and chisel can actually be less fatiguing, and it can make the bone cut without creating any dust or without creating much of dust as compared to the use of saw, where you see a lot of bone dust forming. So if you're using a chisel, we will use the chisel, we'll place it at the level of attachment of the anterior end of the inferior turbinate, and where after elevating the the mucoperiosteum, we will introduce the chisel over here. And then we'll perform the lateral osteotomy cut. Second is, if you're using an osteotome, in that case, compared to an unguarded osteotome, we'll prefer to use a guarded osteotome, because this with the help of a guarded osteotome, you're going to be able to feel the guard through the skin. So that will act as a guide as you're moving the osteotome further up. So it will help you in navigating your osteotomy better. So this is about the internal approach and how you have made a cut through inside the nose. You can either use an osteotome, chisel, or a saw. Now, there are some contraindications to lateral osteotomy as well. If the nasal bones are very, very short, in that case, that can end up jeopardizing the structural support of the nose. So that's why in these cases, we will not prefer to do a lateral osteotomy. Next, if there is elderly patients with very thick nasal skin also, it is a contraindication for lateral osteotomy. Next, let's talk about the external approach. As I had mentioned before, external approach is where we put an external tiny stab incision. So here we have put a tiny stab incision externally at the nasofacial groove, and this external scar may actually be visible later on. Then we begin the lateral osteotomy cut above the inferior turbinate on the piriform crest to save a triangular piece of bone. We can either use an electric Seltzer saw or a 2 mm wide chisel or a osteotome. Then injecting inside and outside the bone before the lateral osteotomy cut with your anesthetic will actually help you in minimizing the bleeding and pain. After you've made the cut, we'll drive the osteotome and chisel along the nasofacial groove and from the infraorbital order and make the oblique cut towards the midline. So that's about our external approach, where basically we are approaching through tiny stab incisions that we place along the nasofacial groove. Third approach is the curved one. Now, I already mentioned to you the importance of the curved lateral osteotomy. Webster et al. Had actually advocated the curved lateral osteotomy because this would avoid the need for performing any medial osteotomy in majority of cases. Because what curved lateral osteotomy does is it ends up producing a green stick type of fracture between the nasal bones in most cases. So, this obviates out the need for you to perform any medial osteotomy where you give a cut along the midline of the nasal dorsum to separate out the nasal bones. So, that's something to remember for curved lateral osteotomy, that it will obviate the need for a medial osteotomy. And in case of curved lateral osteotomy, when you reach near the infraorbital border, you will have to rotate the chisel or the osteotome and make the osteotome cut medially towards the dorsum and infracture the bony wall. So, this is about the different approaches of lateral osteotomy. The most common one that we use is the internal approach to go through it, and this is done to narrow the nasal bony vault. Next is we'll talk about the medial osteotomy. Now, before we discuss the procedure, let's first look into what are some indications and contraindications. Indications would be when bones do not fracture easily at the frontonasal suture after you have given lateral osteotomy. In that case, we will need to perform medial osteotomy. Second is if there is a need for satisfactory infracture or outfracture at the frontonasal suture. Third, when we use a straight lateral osteotomy, in that case, we need to do a medial osteotomy as well. But if you do a curved lateral osteotomy, in that case, we do not require a medial osteotomy. So these are some indications. Whereas looking into some contraindications, if there is a large hump that we have removed, so the bone over here, what happens is it becomes very mobile and weakened at this frontonasal area. So in that case, it is actually a contraindication to performing a medial osteotomy. And second is if you have used a curved lateral osteotomy, because it produces a green stick fracture that can end up extending along the frontonasal suture on its own, therefore medial osteotomy is not required in these cases. Now let's talk about the approach over here and how are we going to do it. So first of all, you will elevate the nasal skin with the help of a retractor. Then we will introduce the osteotome in between the lower end of the nasal bone and the nasal septum. The skin of the nose is going to be lifted with the help of your left hand fingers and displaced above the cutting edge of the osteotome so that you do not end up causing any trauma to the skin above. Then this osteotome is now going to be struck with the help of a mallet. So you'll ask your assistant to strike this osteotome with your mallet in the sequence of 2 taps, like tick tack, followed by a pause, and then again repeat tick tack. So in this sequence, we are going to ask our assistant to strike the osteotome with the mallet. As the osteotome will keep moving up, the nasal bone, if you remember the anatomy that I had discussed over here, the bone keeps getting thicker as you go towards the root of the nose. So that is something that you need to be aware of when you're performing this. Then, as you keep moving the osteotome up and complete the medial osteotomy cut, the nasal bones are going to separate along the midline on each side of the bony septum. And we are going to direct the bony cuts upward and laterally. And it is important to remember that the medial osteotomy cut should not extend right up to the dense bone of the radix over here. And also, medial osteotomy cuts should also not be placed too medially. We are saying close to the midline, we are not saying right in the midline because that will lead to something known as the rocker formation. So, this is how we perform the medial osteotomy. We elevate the nasal skin with a retractor. We insert our osteotome between the lower end of the nasal bone, and the bony septum. And then we lift the finger with the help of our left hand fingers, we lift off the skin so that we do not end up injuring the skin. And then after we have positioned the osteotome properly, we strike it with the help of a mallet and keep moving up in the sequence of tick tack, pause, tick tack, So after doing this, the nasal bone will get separated along the midline on each side of the bony septum. Things to remember is that one of the things is that the bone keeps getting thicker as you go up, and the medial osteotomy cut should not reach the dense bone of the radix, and it should also not be placed too medially because it can lead to rocker formation. So that's about medial osteotomy. Lastly, we have transverse osteotomy. Here also we have two approaches, internal and external approach. So with the help of transverse osteotomy, what we are essentially doing is we are creating a transverse fracture at the frontonasal suture. So let's first talk about the internal approach. So right after you have finished medial osteotomy cut, the osteotome is already inserted inside, right? And you kept going up as you did. Once this cut is complete, the same osteotome, we are going to rotate it laterally to outfracture the bones from their attachment at the frontonasal suture. And here we are going to use the nasal septum as a fulcrum for the osteotome to be doing this out fracturing. At one point, you will be hearing a audible and a very perceptible click, and that will indicate that the transverse fracture has been made. So this is our internal approach where right after we do the medial osteotomy cut, we do not take the osteotome out, rather we rotate the osteotome laterally and place it such that we are out fracturing the nasal bones from their attachment at the frontonasal suture. So that's our internal approach. Second is we have the external approach, which is where we do it separately with the help of a small chisel, where again here we give a stab incision on the upper part of the bony vault. And because we are giving a stab incision, there can be the formation of a external scar over here. So this is about the different approaches, the different steps to performing the 3 osteotomies. Now that you have performed all the osteotomies, what happens after this? We also have to move the bones, right? The purpose of osteotomy was to narrow the nasal bony vault. So the next step right after this is now we have to move the lateral bony wall inward. So what we do is, if we look at the image over here, this is the root of the nose, this is the tip of the nose, and these, with the help of our 2 hands, what we are going to do is we are going to move the lateral bony wall inwards as the nasal bones and the frontal processes of maxilla are moved with the help of our thumb and fingers. So we'll push them medially. The bones will also carry the upper lateral cartilages medially with them into proper position. And once you have done that, the bony lateral walls have now been mobilized, and now they have a new position where we have placed it. After placing it in its new current position, we are going to evaluate the whole of the bridge of the nose by inspecting it as well as palpating it and see if there is any bony irregularities left behind. If there is any bony irregularity, it can either be resected out or we can use a bone rasp to rasp it out. So this is what is done after the osteotomy. Sometimes you may find difficulty in moving these bones inward. So here, after moving the bones bones inward, what we do is we steady the nasal vault by using a gauge piece, and we'll move and make sure that the position has been placed correctly. Now, as I was saying, the reasons why you may face difficulty in moving these bone inwards would be, there are 4 reasons. First reason is if the osteotomy that you were performing was incomplete, if it has not been placed properly. That case, you will not be able to move the bone inwards easily. Second, if there is a high septal deviation, this will actually prevent your moving the bone inwards. So you have to correct this before you can actually shift the lateral wall of the nose inwards. Third is, in case of medial osteotomy cuts, if these are not placed correctly, in that what happens is the wedge of the bone may remain on each side of the bony nasal septum, and this will have to be removed to achieve effective narrowing. So the medial osteotomy cuts need to be placed properly if you are going to do this step right. And the fourth reason over here is the dorsal border of the septal cartilage may be thickened, and in that case, if that is the case, we'll have to thin it down by excising the thick cartilage from the sides with the help of a knife. So, this is about the whole procedure of osteotomy, and what you do right after osteotomy, we will shift the bone inwards and reposition them into their new position. Lastly, we'll talk about some complications that can happen while you perform these osteotomies. The first one I have already mentioned when I was talking about medial osteotomy, and this is known as rocker formation. So, what is rocker formation? What is the reason behind it? When the medial osteotomy is very long and we end up giving it very close to the midline, this is the right kind of incision. This is not the right kind of incision. What happens is when we are passing through the midline, through the thick central triangle, it ends up creating a rocker formation of the lateral bony wall where an angular fracture usually occurs. Now, when the rocker is produced, the pressure exerted on the nasal bones to close the open roof and to narrow the dorsum of the nose will actually end up opening up the nasion. If you remember the different anatomical terms we had used, nasion is the uppermost tip of the nasal bone's suture, and this nasion will open up if we are trying to close the open roof deformity. And when you apply pressure to close the nasion, then this the open roof deformity, the nasal dorsum will end up opening up. So that is what is called a rocker formation. This is usually a complication of medial osteotomy. How do we prevent it? We have to make sure that we do not give too medially this medial osteotomy cut, and we'll also confine the bony cuts to the thin portion of the bone and direct the cut laterally higher up. So that's about rocker formation. Second is, I had mentioned earlier, in case of when you perform the internal approach rather than the external approach, we have less of periorbital ecchymosis and edema. Why does this happen? This occurs because the osteotomy cut extends upwards beyond the area of the junction of eyelid and the nasal bones. So because of this reason, it is seen more commonly when you do a low osteotomy and when you perform the external approach rather than the internal approach. So, to prevent the development of this complication, we will prefer to use a high osteotomy in the root of the nose, and we'll also prefer to use an oblique or a curved osteotomy because it will help in protecting the periorbital area. Third complication is an injury to the medial canthal ligament or the lacrimal sac. Now, the upper end of the lateral osteotomy should be superficial to the medial canthus to prevent the injury to the medial canthal ligament or the lacrimal sac. This medial canthal ligament is actually attached to the frontal process of the maxilla in the anterior lacrimal crest in front of the lacrimal groove. So here you have to be very careful. When I was talking about the elevation of periosteum and lateral osteotomy, I spoke about it. The elevation of periosteum has to be performed superficial to the medial canthal ligament. Otherwise, we may end up causing injury to these two structures. Next complication is we can end up causing an irregular fracture at an undesirable site. This can happen when you try to force or twist the bone without completing the whole osteotomy cut. So that will lead to a fracture at an unpredictable location, leading to the development of a step deformity or depression. How do we prevent this? We have to follow the right proper sequential steps of osteotomy before we go to the last step where we try to mobilize the bones inwards. We should never try to force the movement of the bones, but rather focus on proper technique and try to move the bones only after the osteotomy cuts have been complete. Next, we can have a step deformity. Step deformity usually occurs because of higher placed osteotomy. The way to prevent this would be to use an oblique or a curved osteotomy while still being placed high enough because we are preferring high osteotomy over low osteotomy in the region of the root of the nose because that will avoid the development of periorbital ecchymosis. So that's about step deformity. Next complication is dislocating the cephalic border of upper lateral cartilage. If you remember the anatomy of the nose again, if this was the nasal bone, next lies the upper bony cartilaginous wall, which is the upper lateral cartilage. I remember saying that the cephalic border of the upper lateral cartilage actually does not lie at the junction. It rather lies at a level above, behind the nasal bones. So, if while you're using your periosteal elevator, if it slips under the nasal bones, it can actually end up dislocating the cephalic border of the upper lateral cartilage. And this will lead to causing a depression in this surface of the nasal bone. So the way to prevent this is that we are going to avoid the slipping of instrument underneath the nasal bone when we are performing the step of periosteum elevation. Next is nasal obstruction. I mentioned to you in the beginning that when you're performing a lateral osteotomy, what you're essentially doing is you're moving the lateral bony wall inwards. So we are basically narrowing the nose. So there's going to be some extent of narrowing of the airway in the case that you're doing. But if you end up causing excessive narrowing by the lateral osteotomy, it can end up in a functional problem where the patient complains to you of nasal obstruction. So you have to know how much of the movement of the nasal bones you have to do in your particular case. And lastly, if we use the external approach, it can lead to the development of a skin puncture or a scar externally, which is not a good cosmetic way to approach this. So these are all the complications of osteotomies that we perform in rhinoplasty. If you have any questions regarding osteotomies and rhinoplasty, please note them down in the comment section and I'll get back to you. Thank you.